everybody now. It's retinal challenges, which is a symposium. The moderators are none other than Dr. Lalit Verma and Dr. Natarajan. Of course, they will also invite Dr. Malika Goel, Chaitra Jaydev, Karobi, and Ajay Arora, which are the panelists for the same. So I give over the mic to Lalit and Natarajan. I don't know whether Lalit has joined or not, but I know Natarajan.
Yes, Dr. Natarajan was there. Thanks a lot, Kumar. And at this point, I would like to remind all the audience who's tuned in that the sessions are going to go on for the rest of these. There are 4 sessions planned for today, and then another 4 sessions planned for tomorrow. Today, we have very interesting sessions running in all 4 halls. You can switch seamlessly from one hall to the other. You can see the program on IIRSI.com, and all 4 windows are available there to view if you've registered. And at 7:45 p.m. today in Hall A, we have a mega bonanza of the Film Festival Award ceremony, which will be very interesting. Please do tune in. And handing over to Dr. Natarajan for the retina, colleagues to showcase what they're planning to show.
Hi everybody. I'm not sure whether Dr. Natarajan is here.
Chaitra, you can take over and.
So I was thinking.
We have 4 minutes per session, per talk, 4 minutes, so we have some time for discussion. I will be taking over the hall from you at 7 p.m.
Sure. So on the panel is Dr. Malika, Karobi, and Ajay. I think we should just kick off since we have some very interesting talks. The chandelier advantage in retinal surgery. I invite Dr. Preetham to put up his presentation.
Thank you so much.
Good evening. Good evening.
Hi. Good evening.
Hi everybody.
Can anybody hear me?
Yes, Malika, we can hear you.
I can hear you, Malika. Loud and clear.
Okay, there goes Preetham.
Can you see my screen?
We can see your Zoom screen.
Hi, Chaitra. Hi, everybody.
Hi.
Good evening, ma'am. We'll play the sponsors video, ma'am.
Okay, fine. Sure.
Yes,
Hi,
thank you, ma'am.
Hi.
Hi, Karobi.
Hi, how are you?
Good. How are you?
I'm fine.
Good evening, sir. We'll play the sponsor video.
Yeah, go ahead, madam, please.
Can you see it now, Chaitra?
Preetham, she says she wants to play, the admin wants to play the sponsors video first and then... okay, please. Yeah, there it is. Can we now start, madam? Yeah, I think Preetham, you can go ahead now.
Okay.
Yeah.
Hi, Preetham.
Hello, how are you?
I'm fine.
Is it a 4 minutes presentation each?
Yeah.
And then discussion will be at the end of all the talks, I think, because they haven't given any time for the discussion.
Maybe one question per...
Panel discussion is written there, 6:43 to 7.
Yeah, so at the end of all the talks.
Yeah. Yeah, and I'll be excusing myself about 5 minutes before because I have another session at 7. So,
I'm not able to, I'm sharing my screen, but I should be getting my desktop.
Preetham, it's a video or a PPT?
It's a video.
So there it's chandelier advantage, I can see it.
Yeah, now can you say? Yeah.
Yeah, I can see it.
Okay.
Great.
So,
Hello.
I'm going to talk about the advantages of chandelier system and, the bimanual advantage that it gives in vitreoretinal surgery. And I've chosen some videos which have spanned over the last about 15 years, and how this advantage has changed and modified over 15 years. This is a video from way back in 2005, where we had to use an additional port to place the chandelier. But then I used to prefer using this illuminated infusion cannula, which had a fiber optic which would go right up to the tip of the infusion cannula. And you can see this is a 20 gauge infusion cannula which I'm fixing here. Of course, that time we had to suture these infusion cannulas, and it would give this wonderful illumination. The vitreous, the illumination would be nice, uniform in the vitreous cavity. And right now I'm doing a membrane dissection here, I'm delaminating the membrane, and then it would allow a good membrane dissection. You could use a forceps, scissors, a curved scissors. This is another case of proliferative diabetic retinopathy. You can see how the fiber optic would go right into the infusion cannula, right up to the tip. Now, these are the 20 gauge vitrectomy days where we had to make these sclerotomies. You can see a forceps and scissor being introduced. These are Lander's contact lenses which are being used. Now, diabetic retinopathy, we all know how challenging they are. You can already see some bleed happening. And this is a bimanual surgery which is being done, and this membrane being removed. There is a combined
somebody has
you're echoing. Somebody has put on 2 devices, I think.
Somebody has 2 devices on.
Yeah, everybody mute, so it should be fine. Yeah,
Is it still echoing? Is it okay now?
Yes, it is echoing.
I don't have any other device on.
Somebody must be having 2 devices.
Dr. Karobi has to mute herself.
Okay.
Can you listen? Hello, Chaitra?
Yes, sir.
Is it okay now?
Yes, it's much better.
Dr. Lalit, we were missing you. Please take over the session. Chaitra was filling in for you.
No, I was trying to log in, but it was not allowing me.
I understand. No worries, sir. We started off the session for you. Please take over.
Okay. Yeah. I have a very reason. Carry on.
Okay. So, with the advent of the MIVS, the sutureless vitrectomy system, I think the life has become much easier because now you have the trocar cannula system, and you can see this 25-inch cannula, how easily the chandelier light just fits into the trocar cannula. So you really don't have to suture the chandelier anymore. What I prefer is inserting 2 cannulas, one at 12 o'clock position and one at 6 o'clock position. So you can even shift your chandelier from superior to the inferior position, or you can insert 2 chandeliers if you have 2 light sources. So this is again a case of proliferative diabetic vitrectomy. You can see I'm first using the 12 o'clock port to put my chandelier, and you can see the membrane over here on the disc, and the chandelier allowing me a good illumination and a bimanual dissection being done. Here I'm segmenting the membrane, and when these bad shadows, when they don't allow me to proceed any further, as you can see I'm stuck. All I have to do is I just change the position from the 12 o'clock position. I shift the chandelier to the 6 o'clock position. By changing it 180 degrees across, it will give me a different view, illumination from a different angle, and then I do the remaining surgery and I'm able to remove the membrane effortlessly. So this is the advantage that sutureless vitrectomy has given us. And at the end of the surgery, all you have to do is just pull out these cannulas. Here's another case. Now this is another place where chandeliers and bimanual dissection helps. This was a case of an intraocular foreign body with retinal detachment. You can see there's a retinal detachment there. I'm doing vitrectomy, and there is a metallic foreign body which is incarcerated in a detached retina. You can see that foreign body. Now here I put the chandelier. Mind you, it's a phakic patient, so I have to be careful not to injure the lens. I have put a PFCL bubble on the posterior pole. Now if I were not to do a bimanual dissection here and just yank the foreign body out, it would cause probably a very bad retinal tear. But the chandelier allows me to do bimanual dissection, to dislodge this intraocular foreign body from the underlying retina, and then with the help of, you can see I'm enlarging the sclerotomy to remove the foreign body. I'm using the magnet here. From the magnet, I've taken the foreign body into a forceps and I'm gradually easing it out through the sclerotomy. You can see the foreign body, magnetic foreign body, come out without really injuring my clear lens over there. Last but not the least, another place where chandeliers have found uses in scleral buckling itself. So scleral buckling, instead of really using the indirect ophthalmoscope, all you have to do is put a chandelier, use a cannula, put a chandelier, and most of the steps which otherwise you would require an indirect ophthalmoscope, you're able to do. You can see over here a cryo being done. Now this cryo is being done by visualizing through a biome with the help of a chandelier. You can see how I'm cryoing your retinal break. At the end of the surgery, after drainage, I'm ensuring that my buccal effect is adequate. So I would like to conclude by saying that chandeliers have made life much easier and have improved the success rates of vitreoretinal surgery over the years. Thank you.
Thanks, Preetham, for telling us the advantage of chandelier. In fact, nowadays, if chandelier is not there, you get jittery. because you see, especially I don't start any diabetic vitrectomy without chandelier being there. In others, you can still take a chance, but in diabetic, I don't think so that anybody, because you never know when this use may be required, and bimanual surgery may be necessitated. Even in GRTs, honestly speaking, I don't start because you see, if it's a more than 180-degree flap, sometimes you will require to unroll the flap, and for that you require illumination and true bimanual surgery. I think we'll go on.
Hi, Lalit.
We'll go on. Hi, Nati. How are you?
Good, Lalit. How are you?
Very good.
Hi, Preetam. Hi, Malika.
Hi, Nati.
Hi, Karobi.
So, hi, Karobi. So
Hi,
we'll move on. We'll keep saying hi in between.
Yes.
So we'll move on. IIRSI is there.
Yes, sir.
Yeah.
Hello, sir.
Yes, sir. Hi, Ekta. You are in US now, I know.
Right, sir.
So she has a presentation on not a very common topic, RD with familial exudative retinopathy. Yes, Ekta, tell us.
Thank you, sir. I'll just start sharing my screen.
Yeah, sure.
Congrats.
Yeah. So this is a video I will be playing. Can you see the screen?
Yeah. Yes, please.
Of FEVR retinal detachment and surgical management. The presentation can be in the form of peripheral avascular retina, incomplete angiogenesis, and detachment can be tractional, exudative, or rhegmatogenous. Like in this patient, there is peripheral avascular retina and a simple rhegmatogenous detachment. The brother of the same patient has peripheral typical avascular wedge and father had similar presentation. This is a tractional detachment with abnormal VR interface managed with scleral buckling surgery. The other eye of the patient has stage 4A FEVR managed with encerclage. Sister also has bilateral detachment. VR interface is abnormal. This is a patient with abnormal adhesion to the lens with fibrous vitreous hemorrhage, extensive subretinal exudation, macular ectopia, and pre-retinal fibrous membranes. Persistent fetal vasculature can be seen. Bimanual dissection of the vitreous membranes is done with scissors and the forceps. The traction around the falciform fold is relieved with the help of scissor dissection. And this is the post-operative picture, the other eye of the same patient. And this is the brother of the same patient with bilateral FEVR. A 9-month-old kid with falciform fold almost attaching up to the lens. Lensectomy is done, and then a careful vitreous dissection is started around the falciform fold. The vitreous is very sticky and adherent, requiring forceps dissection. PVD is induced with the help of forceps. Peripheral fibrous tissue is removed with the help of scissor dissection. The whole surgery is done with the AC maintainer as the retina is pulled anteriorly. The retina settles with a fold here. A 1.5-year-old girl with bilateral retinal detachment after 1 year presented with progression with exudative retinal detachment. A 65-year-old lady with extensive crystals in the vitreous cavity and the subretinal space with stage 5 FEVR. Extensive pre-retinal membranes were dissected bimanually. Peripheral exudation and sticky vitreous was dissected. LPFC was used to keep the retina posterior while dissecting the vitreous bimanually from the anterior retina. Breaks were identified. After relieving all the peripheral traction, the retina was settled laser was done around the breaks. Patient maintains 636 vision. Patients can present at any age and remains underdiagnosed. Scleral buckling and encerclage is important. Bimanual dissection is required. Progression can occur and needs a good follow-up. Checkup of family members is mandatory. Thank you. Variable
Thanks, Ekta, for finishing in time. But believe me, people who are listening, I am told that more than 130 countries are logged in and more than 9,000 people are viewing this program of IIRSI. So, any questions from the panelists, or we keep questions at the end? Malika?
I think one is a wonderful surgery, and I think it's a rare and difficult surgery, and I think she has demonstrated very well. And I think any patient like this, I think they should refer to a surgeon who can do wherever they are practicing.
I have a small question for Ekta.
Yeah.
Any genetic studies were done on these patients who had FEVR?
Yeah, we are trying doing genetic study, and most of the time, something that the FEVR families are not at all very keen on doing these studies because it's expensive, and most of them are still it is considered a taboo.
Okay.
So we have been doing, but yes, these are not premature babies. These are the families which are having, but they are not willing, most of them.
Because there is a subsection of children called as Roper babies who have this combination of ROP with FEVR. So it helps many times because there are premature FEVR cases which are atypical ROP cases, So the thing is that is why it would help.
Exactly. So the history of prematurity is very important in diagnosis because they can mimic like ROP. But these are the patients whom the family members are also diagnosed with these conditions and they are FEVR. Now we have planned a genetic study as well.
I think the important thing is to know that, you can prevent many of these things by laser. At the right time, if there is extensive ischemia, then you can prevent this situation.
I think let's move on. We can keep questions till the end because we have to finish this by 7 o'clock. Is Dr. Avneesh Gupta there?
Yes, sir, I am here.
Avneesh Gupta, 4 minutes here to tell us about innovative VR tricks.
Yeah. Can you see my screen, sir?
Yeah.
Yes. Yeah, carry on.
So what I'll speak is innovative VR tricks for complicated anterior segment situation. The time permits me to show only one clip. In the era of super speciality, many at times we are unaware what is happening in other specialties. We also forget to peep into the other specialty about new instrumentation, machines, how can they help in your specialty. Here is an effort to combine specialty to make your surgery easy and deliver better results to your patients. This machine, vitrectomy machine and trocar cannula system are important tools for assisting the other. This is a case of rhegmatogenous retinal detachment, and I had a lens touch during VR surgery. I put silicone oil injection after doing a fluid air exchange. Vision of this patient improved to 6/12 post-operatively. Gradually, cataract increased, and after 3 months, we had this situation, almost white cataract. And this is a silicone oil filled eye, so I expect a rent here and a posterior capsular dehiscence. So I have already placed an infusion cannula. So anytime if you have in dehiscence or drop in nucleus, the oil will come in the AC and the fluid will replace. So you put a cannula, secure a cannula, but switch off the cannula because it will create a positive pressure. The trypan blue dye is put under air, and you need to make not a very large rexus, somewhere around 5.5 to 6 millimeter rexus, because if you have an large PC dehiscence, then you can place the lens over this rexus. Once the rexus is done, you treat this case as a posterior polar case. You don't have to do an hydro dissection. you go ahead and do an hydrodelineation. Don't rotate the nucleus, because if you rotate the nucleus, there are chances that you can extend the posterior capsular dehiscence and the nucleus can fall down. You can see the nucleus is pretty soft and the nucleus is engaged into the phaco probe and a direct Nagahara chop is done. Once one chop is completed, you just initiate the second chop and the nucleus is eaten up. Once you have created space into the posterior capsule, the nucleus is gradually tumbled and brought into the AC, and then it is cracked and we remove the nucleus gradually. You have to initiate your cortex aspiration away from the rent, and you can see we are aspirating the last bit of cortex. Till now, I can't see a posterior capsular dehiscence, but now after removing this, you can see there is a posterior capsular dehiscence in this. And this acts as a primary posterior capsulotomy. You don't have to increase the size. You go ahead, switch on the infusion cannula, the fluid replaces the silicone oil, and silicone oil you can see nicely coming out from the PPC. Just press the posterior lip. The cornea is well draped with the viscoelastic, and you can see the oil coming in AC, and this oil is removed from the PPC. During this process should be very gentle and you should not force, otherwise this posterior capsulotomy will increase, and you see that the PPC is the rent or the dehiscence remains the same, and we inject the lens in the bag. Once you are injecting, do not forget to switch off the infusion. The lens is placed in the bag, and once the surgery, the lens is placed, then you can remove the cannula, and this is the end of the surgery. This is another patient, a 75 years female, right eye, vision finger count 0.9 cup, uncontrolled on all medication, long standing shallow AC. You can see a lot of peripheral antiasenicia. So we planned for a dual approach. What we did is did a vitrectomy with an posterior AGV. So the conjunctiva is incised, a traction suture is placed, valve is checked for the patency. The valve is sutured 8 millimeters behind the limbus in the supratemporal quadrant, which is usually the preferred quadrant. Once it is sutured, we create 5 into 5 millimeters flap. It's very important to remove all the anterior vitreous because the tube of the AGV will lie behind the IOL, and if you leave any kind of vitreous, then it can block the AGV. If PI is done to make two compartments the same, then vitrectomy is done. Tricot is put to identify the posterior hyaloid, and if PVD is done, you can see with the help of a cutter, we are inducing the PVD. This is the V's ring. Once the vitreous is removed, the total PVD is induced, the vitreous is removed, and a sclerotomy is made 2 millimeters behind the limbus with the help of a 23 gauge needle. This is the 23 gauge needle, and we will insert the tube from this 23 gauge needle into the vitreous cavity. Because we don't have any space in the anterior chamber because of the peripheral antiasenicia, and if we place the tube in the anterior chamber, then the patient can land up with lens touch with the cornea touch with the tube, and will have an decompensation of the cornea. The flaps are sutured. the conjunctiva is sutured, and this patient is doing good. To conclude, patients which are thought to be unoperable and was refused surgery elsewhere could be operated and rehabilitated because of two specialties coming together, and that's our strength. Thank you very much.
Thanks, Dr. Avnindra, for these two videos. Any question to Avnindra?
Yeah.
Anybody from the
One
panel?
thing is, I would like to commend him for his ability to do phaco as well as glaucoma surgeries in addition to retina. So that's very.
It's a combined surgery.
Okay.
Joint effort.
Combined cataract with this surgery. Cataract surgery is not done by me. It's done by our anterior segment surgeon. And
Okay. Now, if the eye is sure, if the eye is filled with silicone oil and you still need to put a glaucoma shunt, how do you do that with oil in the vitreous and you don't want to put it in the AC?
Then you can't. The oil will block the shunt.
Yeah. So what I have.
You will have to remove the oil and then put the shunt in.
Even if you can put it in the AC, I think you can put an inferior shunt. So I've had some of my patients where the glaucoma doctor has put the shunt inferiorly, so that it doesn't get blocked by the oil.
That we do in post silicone oil removal surgeries, and we can put it either in the AC or in the posterior segment, depending on upon the availability of the space.
No, what she's saying is with the oil inside. With the oil inside.
With the oil inside, if you enter the AC, then
it will float up and the valve will be down. I think excellent idea.
Yeah, that is
good suggestion.
Yeah, that is good.
Very
okay, Avnindra, for nice videos. I think let's move on to Pukhraj. Pukhraj, are you there?
Yes, good evening.
How is US, Pukhraj?
Fine. COVID is catching up with everyone. So
your new place.
Yeah, place is fine.
Pukhraj is going to talk to us about a common condition, but a rare surgery in a common condition. Autologous retinal transplantation for large macular holes. Yes.
Can you see my screen, sir?
Yes.
Okay.
Carry on.
So I'm talking about retinal transplant in large macular holes. This is a case of a 24-year-old lady who had a history of viral retinitis, which was now treated and resolved. But she developed a retinal detachment as a consequence of that and was managed elsewhere with retinal detachment surgery. But when she presented to us, she had a recurrent detachment with a macular hole, and her vision was counting finger. And so here, for the blooming, but you can make out that she required a large retinotomy, and now we are trying to tackle with the macular hole using a retinal autograft. So the graft is now in place. You can probably make out that it is a little larger than the macular hole size, which is what is recommended. And probably a chandelier can afford you a better bimanual maneuverability. And we're trying, these are one of our first one or two cases, so it was a learning experience as well. Here you can see the retinotomy, or the site is nasal to the disc for harboring the retinal tissue. Typically, the tissue is harbored from the temporal side, the supratemporal side, but in this case, it was limited by the lack of availability of tissue because the relaxing retinotomy is just temporal to the macula. So those were the reasons which kind of forced us to take the tissue from nasal to the disc. So otherwise, the rest of the surgery was okay, and at 3 and 6 months follow-up, this was how she looked, and you can make out the margins of the retinotomy are flat, and this is the graft, and on OCT it looks well integrated. Here you can make out the edges of the whole erstwhile, and this is the graft which is being taken up. So surprisingly, some of the layered structures are still evident on the OCT, And these are 3 and 6 month pictures, but a lot of glial tissue. And so this technique was first proposed by Garewal et al., who proposed to use it when in cases where no ILM was available. However, the expanding indications led to inclusion of large macular holes also. And typically we need a thicker, sturdier tissue because of the limitations of what ILM can do or bridge. So coming to the options for large macular holes, there can be modifications in primary surgery, which we know of inverted ILM flap or a free autologous ILM flap, or an autologous retinal graft with or without ILM peeling. So one case we have done with a retinal graft with additional ILM peeling overlapping the graft so as to prevent its dislocation, especially when the graft is not bigger than the hole. You can have this risk of dislodging the retinal graft. So in those situations, combining the two may be of help. And these are certain other steps which you can, or techniques which you can employ in refractory macular holes, like repeat fluid gas exchange, or use silicone oil, or use radial relaxing retinotomies on the macular hole margin, or use laser photocoagulation to form choroidal adhesions. So Dennis Lamb proposes laser photocoagulation in the bed of the macular hole, but I think very few people follow that. In highly myopic eyes, we can combine this with the temporal scleral imbrication and scleral shortening techniques, or an episcleral posterior buckling or a suprachoroidal buckling. So we can compare and contrast the uses and disadvantages of autologous retinal graft with an autologous ILM flap. The advantages are that the graft ensures fuller fulfill of the retinal deficit, especially in large macular holes, which might be difficult to achieve with ILM. So this is another case that we did. This was an Alport syndrome, and you can make out the anterior lenticulus and multiple retinal crystalline deposits. So Garewal et al. Have proposed that the conventional ILM removal techniques may not help in closing the macular hole because of the ILM issues in Alport syndrome. So here we have taken tissue from the supratemporal quadrant, and here you can see during the surgery it's quite a snug fit, and this is a large macular hole preoperatively, but in the follow-up we have noticed that the graft has shrunk a little bit and there is a small gap. So that is why the recommendation that the graft should be about half this area bigger than the macular hole. So preoperative considerations is that the case should be like a regular macular hole, and surgery is not recommended in eyes with extensive chororetinal scarring or ischemia or neovascularization or active inflammation, because these conditions can preclude obtaining a viable retinal transplantation. Intraoperatively, the size of the graft, as you mentioned, should be larger. The positioning of the transplantation is important, and this can be achieved under the PFCL bubble. Things are much stable, and you can reduce the turbulence during the surgery by reducing the IOP to as low as 15. The mechanism is not very clear. However, glial proliferation is the most acceptable reasoning, and Muller cells and the rod bipolar cells and other cells help in ectopics and apogenesis to integrate the graft. Postoperatively, we need to look for graft integration and make sure that it's not dislocated, and we can also document the functional outcomes with BCVA and microperimetry. Flap displacement and change in orientation are other complications. The limitations are that there is no long-term outcomes to show. And this is a flow sheet which we have created to guide the approach to a large macular hole. And in non-high myopic eyes with healthy peripheral retina, during the primary surgery, we can either employ the inverted ILM flap technique or an autologous retinal graft technique, or combine the two. And in re-surgeries, when ILM is not available and the patient is phakic, we can combine cataract surgery and use the capsule with the autologous retinal graft, or when the ILM is available, we can combine the autologous retinal graft with the ILM lab technique. So to conclude, it is a feasible option in non-myopic eyes with healthy peripheral retina. Thank you. And these are my acknowledgements.
Thanks, Pukhraj. Only one question. You see, in all these macular surgeries, surgery should be the least traumatic.
Yeah.
So I agree, but in a recurrent macular hole or a not responsive, but in a primary surgery, haven't done it. I generally prefer the technique of autologous ILM, graft rather than this retinal tissue that is generally reserved for recurrent patients.
But I have a point.
Can I?
Yeah, our case was that of Alport syndrome. So, that they have said that ILM flaps may not work there. So that's why we chose that as a primary surgery.
Dr. Pukhraj, would you have could you have tried an amniotic membrane graft, because that would be less less invasive surgery and could have given a better visual results also. It is said to give better visual results because it has some retinal regenerative properties. It produces growth factors, and also maybe you have access to amniotic membrane. That would be the next step before the retinal autologous transplant.
So the limitation with all these membranous structures are that acellular and they're foreign material. But anyways, the basic difference between the bridging tissue and retinal tissue is that with ectopic synaptogenesis, it can fill the gap, and some of the studies have shown with multifocal ERG that the foveal peak is somewhat restored. So nobody knows the exact mechanism, but maybe there is a peripheral retinal locus developing somewhere close by that gives some improved functional outcome.
Okay, I think let's move on because we have 3 talks and rest of the questions you can take up later on. Swapnesh Samant, tell us about what do you do in vein occlusion in young patients? Swapnesh?
Yes, sir. So, PS has to stop.
Yeah, please stick to time.
Yeah, yes, sir. So is my screen visible?
Yeah.
Yes.
Yeah. First of all, respects and regards to all the teachers on the panel. I'll quickly start with my case. So this was a 29-year-old female patient with increased prolactin levels, autism, alopecia, insulin resistance, obesity, and so basically she had PCOS syndrome and presented to me in December 2015, where she had already received some injections for CRBO. She had treatments going on for all possible PCOS syndromes. So basically, it causes insulin resistance syndrome later on, which leads to increase in lipids, BP, and glucose, which increases the cardiometabolic risk and leads to a hypercoagulable state, and also provasculopathy as depicted over here. This was the first fundus picture where the right eye CRBO was present with macular edema on OCT. We did a FFA, the left eye was looking okay, and the FFA showed late staining in the right eye and leakages in the later part. We did a basic workup which showed what we already knew, that it was a procoagulation stage. She was already on treatment for hypertension, diabetes, cholesterol levels, schizophrenia, and multiple other disorders also. After the first injection, we opted for Ozurdex, no financial interest. But you can see later on in 4 months, she developed increased IOP, and you can see the cupping increase, which was managed by the glaucoma surgeon. The macular edema, however, responded well. There was waxing and waning throughout 2006 up to December 2006. We also added on to the PRP laser to reduce the anti-VEGF flow. The story didn't change in 2017, and you can see these serial OCTs in the right eye where the edema came and went. Depending upon the affordability, she took Avastin or ranibizumab, and vision fluctuated between 612 and 624. However, towards the end of the 2018, still the left eye was holding on, but on retrospectively looking at the fundus examination, I could make out the arteriolar thinning and venous engorgement. The early 2018 the story was not different. Waxing and waning of the macular edema and injections were taken. However, things turned in a very horrible fashion in June 2018, where the left eye also developed CRVO. So at this point, we tried to investigate her further and thought, why is she having? She already had risk factors, but we thought of investigating her further, and we found that she was APLA positive with positive cardiolipin antibody as well as lupus anticoagulant, which is a severe form of APLA. She continued with anti-VEGF treatments in the left eye, and at the same time, the right eye didn't spare her. She was having recurrent macular edema, so we were treating both eyes at the same time. However, the left eye was always responding better. These are the images from August to December 2018 of the left eye. The vision recovery was also better in the left eye. So these are the images, and in May 2019, after 2 or 3 second opinions, we decided to do an ILM peeling for the right eye, which actually turned out to be, we thought that she would do much better after that. But this was an image post ILM peeling. But even after the ILM peeling was done in the right eye, which was a worse eye, the vision was fluctuating 618, 624. The edema kept on coming. However, the area of edema was limited. We also tried adding some amount of focal laser. The left eye, the same story continued later half of 2019, waxing and waning. However, always she improved. Now the injection intervals between the left eye injections was increasing, and also the right eye. These are the recent images from Jan to September 2020. You can see that only a focal area of right eye is now recurring, and even that is now taken care of by injections. And in 2020, we started giving a Zaltrap. The left eye has just received 2 injections in the entire 2020, which is responding better to that. So these are the recent images of September 2020 of the right eye as well as the left eye. And this is a flowchart up to 2019. She had received more than 35 injections, and now it's almost 50 injections combining both eyes. So ocular involvement in APS occurs in 8 to 88% of the patients, and many of them are women of 40-year-old age. You can have other varied presentations of APS syndrome, where you can have uveitis, you can also have vasculitis, retinal hemorrhages.
Can we conclude? Can
yes,
we conclude?
Just one point, sir. Clinical criteria is very important. Vascular thrombosis plus pregnancy morbidity points to that we should investigate further for APS patients. And also in this young age group, we should not rule out ANCA-associated vasculitis. So these two groups, ANCA-associated vasculitis and APS, should be kept in mind, and emphasis to lower additional risk factors in these patients should be kept in mind. Thank you so much.
Wonderful presentation. Wonderful presentation. Let's move on to Shalabh. Shalabh, time is less, so kindly save some time for us.
Natarajan sir, we are grossly behind schedule. We have to start because the film festival is at 7:45. I think most of the speakers have exceeded their times by a lot of duration.
Yeah.
We'll have to give the rest of the speakers just 2 minutes each.
Shalabh? Yeah, Shalabh. Carry on. Shalabh?
He's muted, I think. Dr. Shalabh is muted.
Shalabh?
He is muted. Yes.
Hello. Hello.
Yes. Carry on.
Yes, so this is a young patient with trauma and yes, and lax zonules. Rexis was done in this patient using the forceps. Oh, sorry. So Rexis was done using the forceps. So one can make out the lax zonules. And during hydrodissection, see what happened. The lens nucleus, popped up and got stuck in the rexis. So this is one mistake that was done by me. And then I tried to phaco and separate this, but you can see in the inferior pole, it is dipping down. Each time I'm trying to engage the nucleus and trying to separate it, it's dipping downwards. So I have managed to get a crack here, but you see what is happening, you know. So this lens is becoming more and more unstable. So trying once again with reduced parameters, and again it just pops. So here I'm trying to put some capsule hooks in order to stabilize the capsular bag. Tried to put in a CTR, but didn't go in. And even in spite of putting these capsule hooks, the lens still was dipping downwards. So then it struck me, because being VR surgeons, we know that if you put in an infusion cannula from behind, the positive pressure from the vitreous would probably help, and that is what actually helped in this case. So now you can see that now the lens is not dipping downwards. So as Dr. Amrinder also showed, if you learn from the experience of your colleagues, or if you're doing both anterior and posterior, you would know that infusion cannula can come handy. So here the infusion cannula actually allowed me to finish my case here, and then remove all the cortex, then put in a CTR. Now the CTR was put in using the fishtail technique. So the CTR goes in. That's one lip, one tip of the CTR, and then the other. The lens still was pretty unstable, so I put in a capsule tension segment using a Hoffman pocket. So here I'm creating an Hoffman pocket, and this is the Ahmed capsule tension segment, and that is sutured there into the Hoffman pocket. You can see the railroad technique of introducing the proline suture, and then the lens is placed in the bag comfortably and pretty much in the center. And that's about it. So that's
very nice. Shut up. We are running out of time. That is the reason I am stopping. Otherwise, we would have a wonderful discussion.
Wonderful presentation, Shalab.
Yes, thank you.
Let's have the last, Santosh, tell us the misguides that an anterior segment surgeon must be aware of. Santosh?
Yes, sir.
Hi, Santosh.
Hi.
Please hurry up. Because, we are
you can stop me anytime, sir. I don't mind anymore.
Yeah. No, carry on.
Yeah. I'll be talking about some of the masquerades that anterior segment surgeons may face. If a patient has scleral pigmentation and iris heterochromia and has palatal pigmentation as well, then obviously these patients have a high risk of developing uveal melanoma. This was a child who was being observed for a long time, suddenly started developing some occlusency and thickening of the choroid, as you see here. And also he had high pressure and a angle as well as a ciliary body mass. So this particular child with ocular melanocytosis had converted to melanoma, and that is the enucleation specimen. Now, if you have a patient with a sentinel vein and a cataract, then you cannot do cataract surgery unless you have excluded uveal melanoma, especially ciliary body melanoma. A patient of this sort can have a large ciliary body melanoma lying around, and that may be missed. Otherwise, obviously, you will have to treat that melanoma first. In a patient with sectoral iris hump like this, it could be a cyst, and it can only be diagnosed on UBM or ASOCT or a solid lesion such as melanoma. And if a unilateral glaucoma in a young individual with correctopia and ectropia on uvea, the strap has failed because there was a melanoma lying behind. So you have to be very careful in a young patient with glaucoma but with correctopia and ectropia on uvea. And for granulomatous uveitis, there are several differential diagnoses, including tapioca melanoma metastasis. For hypopyon, one of the differential diagnoses in a very elderly individual is metastasis, and a 60-year-old male with left eye white hypopyon. This is a patient with large cell lymphoma. One more similar situation, but this was leukemia. So white eye hypopyon causes in elderly individuals could be lymphoma, leukemia. Whereas in a young child, it is retinoblastoma if it has a flat hypopyon, but with this heaped up kind of translucent hypopyon, then that is medulla epithelioma. For hyphema, some of the causes are juvenile xanthogranuloma, and especially if you find these macules on the skin, this is a skin eye disease. And for hyphema, we can have leukemia as a differential diagnosis, and also child with retinoblastoma. This particular child had a echogenic mass in the vitreous with calcification that was ignored, and somebody drained hyphema, resulting in extraocular extension and intracranial extension. If a patient has a zonular coloboma like this, a child, and also a retrolental vascularized membrane, then you should look for medulloepitheloma. This is a child with what looks like posterior subcapsular cataract with zonular coloboma with retrolental membrane. This was medulloepitheloma. In sectoral cataract like this, again with vascularized retrolental membrane with uveitis, you have to look for a ciliary body melanoma. This was a patient with ciliary body melanoma. And last is vitreous haze. If a patient has a lot of vitreous haze, but a quiet eye, cloud, clump, or whatever it may be, you should look for retinal and sub-RP infiltrates, and that tends to be retinovitreal lymphoma. So these are the 10 mask cards for an anterior segment surgery.
Wonderful collection, Santosh. A lot of learning. Unfortunately, I must apologize to all speakers because the discussion was less, because we are very fond of discussion because of the time. Remember that 130 countries logged in and 9500 members logged in. So thanks to all the speakers. Natarajan, Mallika, Chaitra had to leave in between Kairobi and Ajay. We could not have much discussion, but overall, I think presentations were great.
Thank you.
Wonderful presentations.
At least we got to see everyone.
Thank you. I know. Yeah.
Yeah. I think
that's important.
Lalit sir, Natarajan sir, and all the speakers.
And Ekta and Pukhraj also.
We had a fantastic session. I'm sorry.
Sorry, Gaurav, 5 minutes.
Hi, Gaurav. Thank you.
Speakers, but it was a wonderful session. And I think we are a little behind schedule for our next update, and we have some fantastic faculty from across the world. And I would just like to invite the 2 panelists. And sorry, sir, Dr. Lalit, you can finish off the session and then proceed.
Sure.
Thank you, Lalit.
Hello.
Thank you. Thank you, Lalit.
Bye.
Thank you so much,
Amar, and all the team for having us.
Thank you.
Yes.
Hello, I am Renato Ambrosio from Rio de Janeiro, and I am very happy to be here with you in this webinar, another great webinar organized by Agarwal.
Good evening, doctors. We are going to play the sponsors video. Thank you, sir. After this video, you can start your session, sir. Thank you.
Okay.
Thank you, sir. You can start.
Thank you. So without further belongings, it's my pleasure to introduce the next speaker for the keratoconus session, which is my great friend, Farhad Hafezi. He's going to talk to us an update on cross-linking at the slit lamp. Thank you, Farhad. Please join the meeting and share your screen when you can. Thank you.
Dear Renato, dear Susan, thank you so much for the kind invitation. I'm very happy to be here today with you. So the next 4 minutes are dedicated to cross-linking at the slit lamp. These are my, see whether it moves forward now. These are my financial disclosures. Now, looking at what we can do nowadays, keratoconus indication is established. Infectious keratitis is getting more and more solid data published, but we should realize that only a few % of the global population have steady access to cross-linking technology, because for most cases, we perform cross-linking in a lying position in an operating room. This is a typical setup that I'm using. Now, what if we could bring this went forward, what if we can bring this whole procedure to the slit lamp? And this was a dream we have been pursuing for a number of years now. And luckily, the dream now became reality. Let's look at how and why. Why cross-linking at the slit lamp? If you take a country, an industrialized country, then having cross-linking at the slit lamp means you greatly reduce the costs per minute. A procedure room or the doctor's office is so much more inexpensive than the operating room. In case you treat infectious keratitis, you certainly don't want to take your infection into the OR where you do your cataract surgeries, so you can split them and you can share one device in multiple locations. If you look at a country like India, where you have mega cities with organization and ready access to operating theaters, but then again remote areas, then you should serve the remote areas because you need to treat as early as possible. So take the treatment out into the remote areas, increase the coverage, which means democratizing cross-linking. That's how we call it, access for all. Now, if I look at the obstacles that had to be overcome, on one hand, many colleagues said, well, you can stay at the slit lamp for half an hour, correct? Absolutely correct. But nowadays, modern cross-linking is around 10 minutes for keratoconus treatment, depending on the protocol you use, whether it's epi-on or epi-off. And 10 minutes are absolutely feasible. In PAC cross-linking, we are even down at 4 minutes because the Bunsen-Roscoe law is respected. On the other hand, the second obstacle you might want to overcome is a skeptical that will say, well, what about the risk of infection? Well, if you're already in an infectious keratitis case, then all you do is sterilize the cornea, then you have no issue. And please remember, in every cross-linking procedure, also in CXL for keratoconus, you do not only stiffen the cornea, but you kill everything that lives in that cornea. All 4 effects you see here on the slide happen in every CXL procedure. So the cornea is disinfected after CXL for keratoconus. So that's the reason why we believe that we can go to the slit lamp. So if these 2 issues are taken care of, then we can take our vision onto the slit lamp, and it's not only a small device, it's a small high-tech device that covers everything that is needed for all modern protocols. Other obstacles that had to be taken care of were, can we do epi-on at the slit lamp? And I'm very happy to see that my friend Cosimo Mazzotta has managed to intelligently combine everything we know about cross-linking nowadays by performing iontophoresis-assisted epi-on cross-linking at the slit lamp without any oxygen boost. And he has 3-year data he has published. So this door is open too. Another door we opened if you want to do epi-off is that we can very easily and safely remove the epithelium bladeless with 40% alcohol. And lastly, we know that if you apply riboflavin, it stays vertically in a good concentration for 1 hour. So all the things that were open questions have been solved. The device will give you every possibility of modern cross-linking. We developed our own riboflavin. Let me just very briefly show you, by the way, for all indications. This is what you see when you look through the slit lamp. This is amazing. You see the fluorescence. The patient is very steady, even steadier than what we usually see when treating in the lying position, because you can give him the fixation light of the other that we usually use for, let's say, gonioscopy. So the patient is steady, and this is how we perform a 10-minute epi-off treatment without any issues. We even went to longer treatment durations with very high fluence approaches for clinical studies, but this is how we perform the treatment. So in conclusion, CXL at the slit lamp democratizes the access. CXL at the slit lamp is suitable for all indications, epi-on or epi-off, and we are currently working on the iontophoresis-assisted epi-on. Just imagine doing bilateral epi-on, iontophoresis-assisted for all thicknesses. This is when we managed to get the sub-400 protocol from our group and Cosimo Mazzotta's epi-on group protocol together. That's the dream for the next 2 years. Bilateral epi-on CXL for all corneal thicknesses at the slit lamp. Thank you for your attention.
Thank you very much, Farhad. Excellent talk, as always. We all look forward to your great developments on the cross-linking road, and this has helped so many patients in our practices. So next talk is myself, and I will talk about keratoconus and corneal topography. These are my financial disclosures, and I always acknowledge my collaborators here in Rio in Portugal. And one thing is that we evolved from topography to tomography, three-dimensional tomography. And I love the idea of understanding what we're trying to achieve with the weapons we have. And in this philosophy, we have early diagnosis, prognosis, classifying and staging ectasia, more detailed follow-up, patient orientation, and understanding how we can get information to help the patient since refraction up to the customized treatments that we can do today. And we do that with multimodal imaging. Multimodal imaging is the next step forward that we are trying to achieve. And the quest for the enhanced ectasia is definitely to go beyond, but not over. Of course, we start from the slit lamp, and we are not only detecting mild forms of ectasia, but we're trying to consider beyond topography, beyond the surface topography, understanding susceptibility for ectasia progression. This is important for refractive surgery, and is definitely important for keratoconus management because we want to do the treatment as much effectively as possible so that we don't harm the patient when they don't need it. So we understand the prognostic factors. And this is very important that we understand what is form-fluid keratoconus. Jaro Rabinovitz had a great work on topography since the early days, and his classifications when you have no slit lamp findings and typical abnormal topography. Here in a patient with 20/20, this is correct vision. However, the fellow eye of this patient is what I would say this is the form fluid, and eventually this was an agreement with Steve Weiss' editorial in 2009 at the British Journal, the fellow eye of patients with very asymmetric keratoconus. And understanding that this is a need, we don't have a consensus on what is form fluid. There is a huge variability, and including form fluid and subclinical keratoconus in a very nice systematic review done by Maria Picas and Luisa Stirdos group. So my humble understanding of form fluid is that it's a patient with a high susceptibility for ectasia progression. And this is the case that would have a normal topography, would qualify for LASIK, but the fellow eye of the patient had LASIK-induced ectasia. So the right eye had never done any surgery and will be stable until today. And with abnormal tomography, actually more borderline than abnormal, and also borderline to abnormal ocular response analyzed. That was published in 2010. This patient recently was seen. You see the topography from Placido and the topography, the topometric evaluation from the Shine Food. You have relatively good central corneal thickness. That patient would qualify for LASIK. But when you go to the integrated tomography and biomechanics using artificial intelligence, you have a very abnormal TBI, which indicates ectasia susceptibility. We have other examples, but in this 3.5 minutes, I just want to go for the next example, which is the son of this patient that has 20/20 distance corrected mild allergy, and I would qualify this case as the bilateral form fluid keratoconus, and you see the abnormalities here. This is the patient that should understand they cannot rub the eye. This is the patient to understand what we can do with multimodal imaging with AI to improve their understanding beyond but not over in this true revolution in evolution, and understanding that eye rubbing, for example, can aggravate keratoconus and eventually cause ectasia as two different things, you will get a huge step forward to the treatment of ectasia and keratoconus patients. Thank you very much for the attention. So I tried to save some minutes, and I hope we did. So the next speaker, we have Susan Jacob joining us. Thank you, Susan.
No, Renato, next is Alejandro, I think.
Hello, how are you? I have a pre-recorded presentation. Okay, so the technical team has it. Can they present it? Otherwise, I can share my screen.
Can you please put on Dr. Alejandro's presentation? Dr. Alejandro, if you have it with you, please share your screen.
Okay.
Ma'am, can you move forward to another topic, madam?
I go with my
one minute, sir.
Firstly, I would like to thank.
Doctor, your video is ready, doctor. We can proceed with that.
Firstly, I would like to thank IIRSI and Dr. Agarwal for their kind invitation. Infectious keratitis after intracorneal ring segments implantations have been reported both early and late between a wide range from 0.1 to 6.8%. Some of those infections have been late. Boursier et al. In 2003 reported the case of a patient with 3 months after surgery. Hofflin Lima et al. In 2004 in a case series reported 3 patients who had an onset later than 2 months. 1 patient 3 months after surgery, the second one 6 months after surgery, and finally 1 patient had the infection 22 months after the surgery. Galvis et al. In 2007 published the case of a patient who 4 months after the implantation presented with infiltrates and hypopium. Explantation and topical moxifloxacin, topical imipenem, and systemic intravenous and topical vancomycin had good results. Levy and Leaf Sheets in 2010 published the case of a patient who 2 months after femtosecond-assisted procedure presented with infiltrates. The cultures were negative, but the clinical picture suggested infection. Chabayek and Alliot in 2007 also mentioned that they had a case that 2 months after implantation with femtosecond-assisted procedure had an infectious keratitis. Tabatabaei et al. In 2019 reported an incidence of 2.7% of infections. All the 11 cases were caused by gram-positive cocci. They identified the horizontal position of the intracorneal ring segments as a risk factor. The cases were managed with explantation and tunnel irrigation with antibiotics, and 2 of them eventually needed penetrating keratoplasty. Only 1 case had the onset of the infection later than 30 days after the surgery. They found wound gap in 10 out of 11 eyes. They did not find significant difference between manual and femtosecond-assisted procedures with regard to the infection. In conclusion, there is a real risk of microbial keratitis even months after the implantation of the segments. A gap in the incision seems to be a risk factor, possibly because it permits the formation of epithelial pseudocysts in the incision, which, as we learned in the past from radial and adequate keratotomies, seems to be an important risk for late infection. So when the surgeon is in doubt about the architecture of the incision, it's better to suture it. Patient education about alarm symptoms and the need for long-term close postoperative follow-up is very critical. A very appealing new alternative is corneal allogenic intrastromal ring segments from donor corneal bones, since they will integrate with the host cornea. The risk of infection is expected to be much lower. Thank you for your attention. Thank you.
Renato, can I share my screen now?
Yes, next speaker is Susan Jacobs, and she's going to talk to us about CARES so that we can avoid complications with just seeing. Please, Susan.
See my screen. Just one second. All right. Are you seeing my CARES talk? Are you seeing the talk on CARES? Is that the one being streamed?
Yes, the CARES presentation is on the screen.
Okay, all right. Thank you. So, thank you, everyone. We've got a wonderful panel here and a lot of great speakers. And thanks, Renato, for moderating this session with me. We've already had a couple of great talks. I'm going to be talking on a topic which I call as corneal allogenic intrastromal ring segments, a technique. I gave this acronym. I must say that I do have a patent pending for shaped corneal segments and devices in process used to make them. The reason why I had started out this was very similar to what Dr. Alejandro said. It was because of the number of complications that could be seen with artificial intrastromal ring segments, all the way from extrusions, migrations, melts. They can move even years later, and they can have infectious complications, as he very elaborately explained. And also, what you have to remember is even if you've got that safe 400 microns above the intacs or the Kera rings before while implanting, with the progression of keratoconus, that safe limit may be lost with thinning, with progressive thinning of the cornea, and that can potentially also lead to late complications. So, what I thought was, why not make these implants, but create them, do these implants, but create them with allogenic stroma. This is a double-bladed trephine that I designed and is being currently marketed by a company in India called Madhu Surgicals, and here is what it looks like. This is what you get, a ring of stroma, and I'll just show you in greater detail how to do this. That's basically all the epithelium and all the endothelium that's being removed. So this is a donor corneal scleral rim that has been mounted on an artificial anterior chamber, and I make sure that I've removed all the epithelium, also all the endothelium. That's the double-bladed trephine that's being seen. And what we do is go ahead and punch it out. As seen here, that's the stroma, which is got, and from that you can cut out segments. Now these trephines are available in a couple of different sizes so that you can get different thicknesses of segments. The femtosecond laser dissected channel has already been created in this patient's eye, as you can see here, and now it's very easy actually to push these segments in. I have soaked these segments with riboflavin and they can go in easily. Possibly Jack Parker, who's also here, is also doing this, and he has some different ways of getting these segments into the tunnels, and he'll probably be able to discuss it during the panel discussion. So here's some post-ops. You can see this is the mid-depth placement, so you don't have to go as deep as you would do in intacs, because so the depth of placement is really not an issue anymore with allogenic segments. And you can see the very quiet eyes. I don't give steroids for more than a month and a half, very similar to my post-cataract protocol. So these are the disadvantages that I mentioned of synthetic implants already discussed, but what natural implants does is it avoids all these complications, and also you can implant it in much thinner and steeper cornea. So generally people stop around 53, 58 diopters for synthetic segments, but here you can really go much thinner and much steeper. In fact, I've avoided a great number of DALCs with this technique. Here's a patient where I used it for post-intact melt, and I'm going to go through this video really fast. This was a patient who had a post-intact melt, and you can see what I've done is remove it out and fashion these CARES segments from the donor corneal scleral rim, and then I've placed it into this area of melt and then anchored it on either side with sutures, and also put bridging sutures on top, and basically that's how I solve this patient's problem. And you can see the post-operative appearance 3 months after suture removal with an intact segment on one side and the CARES segment giving very good resolution to his problems from the other side. So a lot of effect can be got from these segments. You can see great amount of flattening, again about 14 diopters of flattening here in this patient, and you can put single-sided segments, you can put double-sided segments, you can change the depth, you can change the optic zone, and you can also change the thickness. Here's a patient where we avoided DAL, and this video is courtesy Jack again here, and it just shows beautifully how the cornea is flattened out. You're comparing the shine plug images, and this can also be combined, in a synergistic way with the other modes of treatment. Again, this is a picture I've borrowed from Jack, which shows a huge amount of flattening from about 83 diopters to 62 diopters, and you can actually see it very evident in the shine plug image. This is an image which I just pulled out because I found this way that Jack was showing this shine plug image comparison really beautiful to actually explain to the patient also how the difference is made. This is the red is pre-op and the blue is post-op, and you can see the flattening that you've got. I think with that, I'll come to the end of my talk. Thank you so much.
Thank you very much, Susan. Excellent talk. Do we have time for questions?
We do. We could either do all the talks in the beginning or and leave the panelists at the end.
Maybe I just don't want to miss this opportunity to ask you: do you have a nomogram? How you plan the thickness of the segment that you are implanting?
Well, the nomograms are actually we are doing it very similar. The placement of segments and about whether to go single segment, double segment, all that is very similar to the synthetic ICRS. So you can see the type of astigmatism. Is it more of a coma? Is it more of astigmatism? What is it that you're intending to correct, and to do that? And you use thicker segments for getting a greater effect. So if you implant the full thickness segments, which is about 6.5 and 8 millimeter trifine inner and outer diameters, you get, as I showed you in Jack's case, almost about 20 to 25 diopters of flattening, if I'm right. So, and you can also put very thin segments. You can actually do a lamellar dissection of the cornea and really get it down to very, very thin, or you could just cut the segment into just split it with a Sharpie and get it to be really thin. And I've used it for patients with very early keratoconus also, and it gives you this improvement in visual quality. Jack, would you like to add something here about your experience?
Well, CARES has really been a revelation in our practice, and we're so grateful to you, Susan, for innovating it. I think that we have been doing intacs for a long, long time, and there's some variability in patient results, but what we normally expect is to see something like 4, 5, 6 diopters of flattening, and that is typically a function of the thickness of the segment and also the depth of the segment. You have to place the segment deep to minimize the risk of extrusion and overlying corneal melt. And one of the beautiful things about CARES is because it's so much safer, you can use a much thicker segment and you can place the segment much more anteriorly. And as a result of being able to use a thicker and more anterior segment, you can get dramatically increased amounts of flattening. And I would say that the norm for us is to get something like 10 diopters of flattening, but we have seen as much as 38 diopters of flattening. And when you're talking about flattening a cornea by almost 40 diopters, you realize what a revelation this technique is, because you truly are taking people who would otherwise have a doubt or a PK and then restoring them to much more normal anatomy so they can wear glasses or contact lenses. These images that Susan shared were prepared by a researcher in our lab named Philip Dockery, who has since moved on to become a oncology fellow with Carol Shields up at Wills. But he has been compiling all this data for us, and it really is shocking. You really just have to see it with your own eyes to believe. It's kind of like Garrett Mellis's endothelial keratoplasty. You sort of theoretically understand the concept, but you see one patient with it, and then suddenly it dawns on you what a big deal this is.
Excellent. So next talk is my colleague Bill Tratler from Florida. He's going to talk to us about his indications and outcomes of CrossLink. Thank you, Bill. Welcome.
Thank you so much. Great to see everybody. I love being here. I'm starting my timer because you got to be right on time. Okay, so my disclosures that are relevant are Avellino Labs, Avedro, CXLO, and Oculus. I think the main challenge we have right now is keratoconus is often discovered late. Because one of the major problems is that the slit lamp exam is often normal. The keratoconus has to be much more advanced to identify it. So we're often seeing patients in their 20s, 30s, and 40s with significant keratoconus. Why aren't they being caught earlier? Let's just look at these 4 patients. I think if we look at them, and we're now talking about form fruits keratoconus, but these patients have a good amount of keratoconus on tomography. But take a look, their uncorrected vision is 20/20. This is not even, they don't wear glasses. They feel like they see great. This is why patients often can present late with keratoconus. So our goal is to try to identify keratoconus early, both keratoconus and also post-LASIK ectasia. And the key also is that when patients start to develop keratoconus, especially when younger, they can progress quite quickly. So here's a patient, 10-year-old, and in 3 months, they had dramatic worsening of their keratoconus with an increase in Kmax, but it's also this difference map. If you look, it's not just the Kmax getting steeper, but it's the flat part of the cornea getting flatter. It's causing significant worsening of their irregular astigmatism. So the difference maps really help us show how dramatically they can get worse. But it also happens in our older patients. So I hear people saying that, oh, if you're over the age of 30, you don't have to worry about progression. That is not the case. I know everyone here agrees with that. Here's a patient who's 48. They already had Kmax at 55. They go up to 58.6 in 2.5 years. You can see the difference map, again, showing significant worsening over this time period. With LASIK patients, we often see some irregularity in the shape of that myopic, you should see a nice round flattening of the cornea with myopic LASIK, but sometimes there's these little divots or this little triangles, and you wonder, is this a sign that the patient may progress? The patient's fellow eye already had ectasia, so I was following them very closely. You can see here that over 5 years, the patient continued to just slowly worsen, and this is the fellow eye of an ectasia case. You can see the difference map showing this steepening below and a little flattening above. So with that in mind, what is the purpose of cross-linking? Dr. Avazi shared with us this beautiful new technology he has. The goal is to stop progression, but there's more than that. Like Jack Parker just discussed and Dr. Jacob, we also want to see our patients get improvement in shape of their eye, and actually cross-linking will deliver that. Many patients get flattening and reshaping of the cornea, and that can result in improvement in their vision. So here's a patient, and we often see studies of 1 year and 2 years, but look at it 3 to 5 and 7 years, you see these patients have significant changes in their corneal shape. And this patient had nice flattening where the Kmax went down, but it's more than that. It's the reshaping that occurs where the steep part gets flatter and the flat part gets steeper over this time period. And this patient gets improvement in their vision. So you can see this nice change over time. Here's a patient, it looks pretty normal. This is from February of this year. I saw this patient and look, this patient looks pretty symmetrical. Does this patient have keratoconus? Well, believe it or not, this patient actually already had cross-linking. This is how the patient started off back in 2017. They underwent cross-linking, and now look at the change in shape. It looks much more symmetrical, and the different maps explains what happened. The steep part got flatter, the flat part got steeper, and it reshaped over time. And what we're seeing when we look at many of our patients, again, there's variability in the results, but some of our patients get this strong response where every year they get further improvement in their time. So there's a patient that had cross-linking, then 15 months later, they're flatter, but they keep getting flatter. This is 2 years, 3 months, flatter at 3 years, and at 5 years, even further flattening. This is incredible change over time. So that our goal is to identify keratoconus early. Young patients are at high risk for progression, but be aware that cross-linking can help all our patients, regardless of age, and hopefully we'll see this reshaping when they do undergo cross-linking. Thank you very much.
Thank you, Bill. Thank you very much, Bill. Susan Jacobs, do you want to introduce the next speaker, please? So next speaker is also a good friend, Ala Al-Nasuri, who's going to talk to us about his indications for toric ICL and ICL for keratoconus.
Okay, thank you, Renato. Susan, you can unmute your microphone.
Yes. I had a great introduction prepared for you, Ala.
Thank you very much. Thank you so much. I can give you my 4 minutes to introduce me. Ladies and gentlemen, that's my pleasure to be with you today. Thank you for all the organizers, Professor Agarwal, Dr. Jacob, and all the team. It's really a pleasure. It does not actually replace the physical meetings, which I hope we're going to restart this very soon, but at least we have a good chance to see every and each one of you. Now, in this few minutes, I'm going to share with you my experience with the ICL and toric ICL in keratoconus. These are my financial disclosures. I'm consulting to Star Surgical, the manufacturer of the ICL. Now, the main point, this is a very easy talk, very easy job given to me. The importance of this talk is that today we are seeing more than ever patients with keratoconus who have a good visual acuity. And this is because of the development of the diagnostic tools, imaging, procedures, cross-linking, intracorneal ring segments, whether PMMA or human segments. So nowadays, we are having more and more patients who have stable keratoconus or stabilized keratoconus. But these patients always come and ask, okay, doctor, I'm happy that my cone is stable. Now, what about my vision? I need to improve my vision. I need a visual rehabilitation. And many of these patients are high myopics or have compound myopic astigmatism. So in my practice, the phakic IOL and especially the ICL and toric ICL have a big role in management of keratoconus patients. The most important thing is to select the patient properly. These patients have to understand that this is not a corneal surgery, this is a refractive surgery. So we are dealing not with the pathology, not with the keratoconus, but with the refractive error that is associated with the keratoconus. So the patient to start with have to be satisfied with his own corrected visual acuity with his own glasses, satisfied with the quality of vision, of course, together with all the other regular criteria for phakic eye. This is an example of 3 eyes. The 3 have keratoconus, and the 3 actually came for visual rehabilitation. The first patient on top here has a keratoconus with high coma, and he has a very good...
Excuse me. We are seeing the first slide.
Oh, really? I'm seeing this.
Yes, we cannot see only one slide.
Yeah, I think you need to take out of the dual mode of screen.
Are we okay?
Yes, now we can see the presentation.
Okay, so I can skip, I can go to the last slide. Okay, so this was to show you 3 different patients with keratoconus. All of them have 20/20 or 20/25 vision. The first patient have, as you can see here, a very good MTF. So objective measurement of the quality of vision is great. So the patient is happy. This patient is a great candidate for phakic intraocular lens. Now the second patient still have keratoconus, high error, high coma as seen here, and his MTF is very acceptable. This again will be happy if you use a toric lens. The third patient can see 20/20 vision with not, his error of reflection is not very high, but you can see that his quality of vision as measured objectively with the MTF curve is very low. So this patient is not a good candidate for phakic intraocular lens, though all the patients could see good visual acuity with that corrected view. An example of a patient who had cross-linking, and then 2 years after stabilization of his cone, he has a high myopia, about 16 diopter of spherical equivalent, and his MTF, as you see here in pink, is acceptable. After inserting an ICR in his eye, his myopia went down to almost 1 diopter, and he preserved his quality of vision. So this patient was very happy after the surgery, and we are delivering what we are promised. And more important is to promise what we can deliver. So we have a series of patients, 46 patients, stable keratoconus, or patients who had cross-linking, or patients with intracorneal ring segments. 1 year after the surgery, this 93% of these patients could see 20/40 or better. Pre-operatively, all these patients could correct to 20/40 or better. So after the surgery, 93 could see 20/40 or better. And there was a gain of distant corrected vision. Of course, this is not as important, as accurate as patients with compound myoptic astigmatism without keratoconus. But for these patients who already have a compromised visual quality of vision, that's an excellent outcome. The refractive outcome at 1 year was still very good. Between plus and minus half, we had 92% of the patients. Still lower than patients with compound myoptic astigmatism, but for patients with keratoconus, it's an excellent outcome. MTF over 1 year was stable. You see here, this is not the best MTF patients can have, but for patients with compromised cornea with keratoconus, at least we maintained the quality of vision that we had before the surgery. So to conclude, I do believe that ICL and toric ICL are very predictable, very effective, and very safe for the correction of compound myoptic astigmatism. The key factors here is to explain to the patient that this procedure is not to correct the keratoconus, but to correct the myopic astigmatism that is associated with keratoconus, to select patients with good preoperative visual acuity, and if you do this, the patient satisfaction is extremely high in that sense.
Thank you, Ala. Very, very interesting. So it's very important to, as you just mentioned, that we have to differentiate refractive surgery from therapeutic surgery. This is a very great point, and I love the way you look at the wavefront data so that you can select the patients. For guys, for colleagues that don't have the technology like eye trace or OPD scans, I would say that the distance correct vision and the question, the simple question, how are you doing with your glasses, may be the best possible indication for the patient that would benefit from the toric ICL or the spherical ICL. Don't you think so?
Yeah, absolutely. If you don't have access to, but nowadays I think most of the corneal imaging have a way to objectively measure the quality of vision. I found the MTF is very helpful. Of course, the point-spread function, everything is based on the point-spread function anyway. But yes, I do agree that if you don't have access to such objective way to measure the quality of vision, some longer discussion with the patient can give the surgeon a clue whether the patient is satisfied or will be satisfied after the surgery. Yeah.
I'd also like to ask John Chang here, who's also one of the we have a lot of presidents of ISRS here in this group. So this is really a very prestigious group here. To give his opinion about the use of ICLs. I know you do a lot of refractive surgeries, John, there in Hong Kong. To give us your opinion. John, you have to unmute yourself. Please unmute.
Sorry, can you hear me?
Yes.
Yeah, I love the ICL. I've been doing it for years, and for refractive and also disease cornea. And I completely agree with Allah, and also with Renato. You know, I asked the patient also, how are you doing with your glasses and doing well, the seeing well? The ICL goes very well. Nowadays, with that central hole in that lens, we're not seeing cataracts anymore. So it is really a great lens. And the sizing is getting better. So it's really perfect for cornea, cornea diseases that have degenerative cornea that are stable. It's great.
Jod, would you like to also add something? What about what is the lowest power that you would possibly think of correcting with a toric? Let's say you have very low residual powers, let's say -2 with -3 cylinder or something like that, and the patient does want to get rid of glasses. Would you go ahead and do toric ICL in such a patient, provided he's suitable in terms of ACD and everything else?
Yeah, that's for me?
That's for Jod.
Jod Mehta.
Sorry. Yeah. Hi, Susan. Yeah. No, I agree. I mean, if it's a keratoconic patient, I mean, similar to what Alo and John basically said. The only thing I'd add in there, I do cross-link the patients because same as Bill basically mentioned in his talk, I've seen patients in their mid-30s who do progress. So if they're going to go for the ICL option, I will cross-link them prophylactically every single case before doing the ICL. But I mean, your example of a -2, -3, if they patient. But I think ICL, as long as it respects the AC depth and stuff, I think that's fine. I would go.